the proposal that was part of the Rosen report. I don't know if that's what they're construing as having provided
I
funding.
didn't reject anything.
You did not,
Here.
Representative Martin, no, you did not.
Okay, well, I'd like to get a feel for that, and if you could provide us with that information, I appreciate it. Thank you.
Representative Rotunda? No? Representative Sandler?
Yeah, thank you. Commissioner, I'm looking, and maybe I'm just missing it, but I know that funds are being transferred in the budget from the Fund for Healthy Maine, but I don't see a change in the statute. Do we have a language piece about changing the language about supplement and supplanting? Is that in my language piece that I should be finding?
You have a proposal in the budget. This is a proposal that you've had year after year related to transfers that will precede this administration that have been transferred out of the Fund for Healthy Maine into the medical services account.
Representative Hyman?
Yes, thank you, Senator. I'm thinking about a public health crisis in the state. If that were to occur, such as we saw with the Ebola person, if that were to be expanded or be another issue, do we have the resources, the messaging, the process in the state to respond to that in a way that matches best practice?
So Maine is very different from a lot of other states related to public health infrastructure. Many states have county-based, city-based, public health entities. The fact of the matter is that public health in Maine largely relates to the partnership with community providers, with hospitals, EMS, etc. And the support that has been provided has been through the regional resource centers, the structure that exists around public health emergency management. Public health emergency management has been through those collaborative partnerships that really have been focused on supporting the community providers, along with certainly the support from MEMA and from the Department of Health and Human Services within the CDC. There are many comprehensive plans that have been developed around the response to emergencies, public health emergencies, and we can provide those to you to provide you with greater appreciation for the discussions and for the planning that has occurred around that.
Thank you. Is there a central messenger?
Well, you know, that's a great question, and I'm sure we could have a long conversation about the Ebola situation and how all of that was orchestrated. It does call into question. Much of that fell to the Department of Health and Human Services to convene and to reach out to the hospital CEOs in particular, the regional resource coordinators. MEMA was also very much at the table and involved. It involved EMS. But it is really about convening and attempting to coordinate. But certainly at the end of the day, many of those providers are making decisions about what they can do. In that instance, they were talking about what the number of beds that they could offer up. We've worked on developing memorandums of agreement with those hospitals that try to stipulate what role they'll play. The state has had significant experience going back to after 9/11 in the development through the funds that were provided, the bioterrorism funds that were provided, the hospital. A lot of funds that flowed to the state were actually around hospital emergency preparedness. But a lot of that has influenced the development of the regional approaches that are tapped into when necessary related to as situations develop.
Thank you. So there is no central messenger.
I suppose it would depend upon the issue at hand, whether it's DHHS, whether it's MEMA, that fulfills that role.
Thank you.
Representative Martin?
Thank you. Since I am the poster, whatever it is, for Ebola, and my district was the center of attraction. I do think that the state needs to develop an ability to have someone who is overall in charge. I don't know what you want to call that person, whether or not it's going to be the commissioner, you as a commissioner, but it was a confused mess in terms of the delivery of services and how things would be delivered and who was responsible for what. And even though I wasn't in the legislature, I was involved. And I think that, I'm glad it was raised because frankly, I probably would have gone to something else, but I'm not saying I don't want to condemn or attack anyone, but I do think that we need to develop a mechanism when certain things happen that there is someone who automatically is available to be the central focus. And the communications can go to that one location and dissipate it in manner, shape, or form, which didn't happen. So I'm not saying it should be your department or who it might be, but whether that's Maine State Police or whomever, but the lack of cooperation, coordination, and it's, everything was, and if you want to talk to local people about it, they love to talk about it because they're still talking to me about it.
Yep. And, you know, I'm happy to spend more time talking with you about this because I think in anything that we do, the important part is how do we reflect on what occurred and how does it continue to inform structure. There was a lot that the Department of Health and Human Services absolutely did to...
Well, I'm not questioning your involvement or you were very helpful. I don't want to imply that the department was not helpful.
No, what I meant was, but it calls into question who can oversee, you know, I brought in the state police after some of this to talk about. I mean, the chain of command becomes a big issue in a situation like that. You know, I've looked at studies of other situations and cases, and there's a lot of discussion about what is the role of more, forgive me for the term, but more of a military type operation that is about the chain of command. Ultimately, the governor is responsible. There are, as you know, statutes that deal with emergency declarations and authorizations that the governor can establish that create that chain of command. They're not used often because of what they take away for authority from others, but it certainly calls into question how you create the accountability and the functionality across state agencies in particular, and then EMS as a good example. I mean, we were speaking with the hospitals in Fort Kent, the EMS, the state police, but how do you create the type management of that chain of command is a significant issue.
Right, and I think before we get into another situation like that, we ought to figure out a mechanism of how it should work. And I'm glad that the issue was raised as something to look at.
Thank you, Commissioner.
Thank you very much.
We have got a list of 3 this morning. Can we handle that? Rachel, Charlene, and Alan. Good morning.
Good morning. Senator Hampton, Representative Rotundo, and the Joint Committee on Appropriations, Health and Human Service Committee. My name is Rachel Dyer, and I'm the Associate Director of the Maine Developmental Disabilities Council. We've had a couple of our personnel in front of you more than once over the past several weeks, so you can refer to the written testimony for who we are and what we're doing. And I guess I would to just remind you that our charge is to advocate on behalf of all Mainers who are impacted by developmental disabilities. So upon reaching adulthood, the availability of individual and family supports changes from a model of entitlement to eligibility. And to be eligible for developmental services, an individual must have substantial functional limitations in 3 or more major life areas. So So to access developmental services or to access some of these other waivers, people have, pretty significant needs. Specific to developmental disabilities, in December of 2008, the total wait list for adult developmental services was 69 people. And 6 years later, it was 1,535. So that's an increase of about 22-fold, approximately. Over the past several years, the Developmental Disabilities Council has noted with appreciation the attention on the part of the legislature and the Department of Health and Human Services towards addressing the waiting list, especially for those assessed to be at risk for health and safety issues, so the priority 1 people, priority 1 on the Section 21 wait list. The council has participated in a number of initiatives undertaken by ODES and others to look at this issue, to address eligibility, to address access. While the overall numbers have increased a lot, thanks in part to the 126th legislature, we expect to see a pretty significant reversal of this trend this year, regardless of the actions of this legislature. The council wholeheartedly supports the initiatives in the governor's budget that address the needs of individuals and families who are waiting for developmental services. However, while ODES provides services to approximately 5,000 individuals, there are 1,000 more Mainers who meet the federal criteria of having a developmental disability, some of whom receive services through another section of MaineCare, one of the other waivers, Section 19, Section 20, Section 50. Some receive mental health services or personal care services, such as 65 or 96. Some of these services create emphasis on alternative diagnoses, which may or may not be the most efficient or effective way to provide care. And many of these people are people with developmental disabilities who are categorically eligible for MaineCare but receive no or limited paid services and who rely upon family members or community members to assist them. Some people do really well with no services at all. And we hear from many Mainers with significant intellectual and developmental impairments who just simply don't qualify for services. They struggle to obtain and retain housing, transportation, employment, and health care. They're disproportionately poor and impacted by issues such as Maine's response to the Affordable Care Act, affordable housing policy, and various income-based supports, such as the SNAP, TANF, general assistance, heating subsidies, and such. The council is concerned with the reallocation of general assistance funds, as it is likely to have a negative impact on vulnerable Mainers, including those with developmental disabilities, their families. We believe that families and communities are stronger when all of its members have access to safe and decent housing, adequate food, and quality health care. And in closing, the council does strongly support efforts to fund eligible individuals to receive the services that they need for their health, safety, and to contribute as valued members of their communities. Thank you.
Thank you. Senator Haskell?
Thank you. Just in general, you talk about people who simply do not qualify for services. Is that based on income? Is that usually the drop-off where they still have significant needs, but their income just hits that
No,
so
I think
what's
the folks who that we're seeing are typically people who maybe have an IQ score that's a little bit too high to qualify for them for developmental services, and don't have another type of significant diagnosis. They're so.
Okay, on the margins.
So they may be working very much on the margins.
Thank you.
Seeing others? Thank you.
Thank you.
Arlene?
Senator Hammer, Representative Ortega. Rotundo, Representative Pettini, members of both committees. My name is Charlene Kennelly, and I'm here today on behalf of the Maine Association for Community Service Providers, MACSP, I won't do the mouthful again, to support the portion of the budget dealing with elimination of the Section 21 waivers. First, we really want to recognize the commitment on behalf of both the legislative and executive branches trying to come up with resolution to this challenge. And I particularly want to recognize former Senator Flood for his never-ending commitment. Intellectual disability is a lifelong condition. It manifests itself before age 18 by statutory definition and is reflective of lifelong support needs. Whether those needs are paid supports or natural supports, they remain for a lifetime. In addition, let me say first, MaineCare, Medicaid, is the only funding source for this population for long-term supports. There are no private pay situations, there are no long-term care insurance options, it's strictly MaineCare. And in addition, because people are living longer as the general population is, so is this population. What this means is that when a young adult enters the adult support system at age 20, their need for support can potentially tie up that Medicaid dollar for 40, 50, 60 years. Section 21 began in Maine in 1983, and it was used as a vehicle to provide community-based services in order to close state institutions and eliminate placements in large congregate boarding and nursing homes. From the beginning, and this is very important, it was designed to have enough flexibility to accommodate the support needs of even the most significantly medically or behaviorally challenged individuals. This has proven to be an effective approach and has delivered high-quality service. In 2008, for the first time in its history, Section 21 was closed to new applicants, and the wait list began. Today, the wait list has over 1,000 people. Every day a person goes without support he or she needs. Those skills are lost, and caregivers, who are usually family members, are strained. When the person finally enters service, the intensity of their needs is greater than would have been the case had they received services promptly. We recognize that supports are labor-intensive and costly. We also recognize that the demands for these services will continue indefinitely. Historically, since 1983 really, roughly 50 to 75 people annually exit the Section 21 program, and frankly, usually that's because of death. And at the same time, roughly between 100 and 125 young adults leave the public school system and turn to the adult system for support. As you've heard, and as Representative Stuckey was discussing earlier with the Commissioner, the payment methodology and system design for Section 21 is undergoing significant revision right now. We've been working very closely with the department over the past several years, really, on this initiative. The new system is scheduled to come into effect in January of 2016 with kind of a rolling one-year implementation phase. We do have some concerns about parts of the proposal. We have some fears about how adequately what's currently on the drawing board may meet the needs of those, again, specifically significantly involved and challenged individuals. We will certainly continue to work with the department. We hope to be able to work out an implementation. But in the interim, because of this opportunity, we would like to offer one suggestion for your consideration during your budget deliberations. The January 2015 department waitlist report is the most recent one that I have seen. And it indicated that there were 1,060 people on the Section 21 waitlist. Of those 1,060 people, 586 were already receiving Section 29 services. And again, of those 1,060 people, 335 were on both wait lists, so they were waiting either for Section 21 or Section 29, whichever became available first. Paid support from direct support professionals is expensive. Using the direct support rate developed by the department's consultant who's working on this system change, paying one direct support professional 24 hours a day, 365 days a year, so one person, would cost the state $162,761. We believe that if Section 29 benefits were expanded somewhat from the current roughly 23 hours a week maximum benefit to at least 40 hours a week, which would then allow family caregivers to work full-time, be able to continue their jobs, etc. That would cost $54,254 annually. That's not a solution for everyone, but we do believe that it's something that could be looked at. Attached to this testimony is a summary. Some of you have seen it, but it's we tried to get one page or a page and a half, but brief summary of what we believe are system redesign possibilities and changes that can really move us to making sure that the services we're providing are the most effective and efficiently delivered and responsive to individual needs possible. Thank you. We'll certainly be available for work sessions, individual primers on intellectual services or what have you.
Representative Jorgensen.
Thank you very much, and thanks very much for being here. I just want to get this clear. People on Section 29 who are waiting for Section 21, Section 29 provides a lighter level of service, basically.
The same service package is
But just not as
available,
much.
but there are caps. Right now, it's a dollar cap, but that translates into roughly 23 hours a week of support for home, work, and community integration.
So that's presumed to be sufficient for a person. There's a lot of people who that works for, but the people on Section 21 are there for want of for the more intensive resources.
Correct. It is far more comprehensive.
So this change to the number of hours you're proposing, would that be something that would be eligible for everybody in Section Section 29, or would it be just for people who are otherwise be eligible for Section 21? Or this number you've
It would be
calculated?
it would be available for everyone receiving Section 29. Technically, the eligibility for both of those waiver programs is being eligible for institutional care in ICFs for individuals. So it's the same condition or medical assessment for both waivers.
Thank you very much.
Thank you.
Senator Grant?
Thank you, Mr. Chair. Charlene, it's great to see you.
You do?
I enjoyed my tours with the Uplift programs in Gardner and Farmingdale, and learned quite a lot with the primer that you gave me. Can you explain how or why people would be on both lists? If they're determined to need one level of service versus another, why would they be on both lists, wait lists? Did I misunderstand that?
No, you didn't misunderstand at all. To tell you the truth, I've never understood because, and I've been around for 50 years, so because the eligibility is the same, I think it's a historical evolution. Section 21's been around since 1983. Section 29 was not available until, well, certainly after 2000. 2006 maybe was when that waiver was developed. And it was really it was intended to replace a state plan service that called freestanding day habilitation, but that did provide day supports for young adults with intellectual disabilities still living at home. When FSD, freestanding day hab, went away, Section 29 original intent was to be the replacement for freestanding day hab. But again, since it was created, home supports have been added as an additional option along with some other services. So they're really very much the same. And there is, the individual assessment that's in process for people with receiving Section 21 is not, at this point, even going to be implemented in Section 29. So the distinction is pretty fuzzy right now.
Representative Katine?
Thank you, Charlene, and thank you for the constructive suggestion. I know you'll be at the work sessions,
Oh, yeah.
as you always are. You're usually not alone, so, and then interested in hearing again, the department's thoughts on this. It seems that, again, if you're doing the equation, right, if there's a variation of the suggestion or the suggestion that we set, is trying to figure out the number of people that, would be interested and be appropriate to maintaining the Section 29, even if Section 21 was available to them, I would think. The question I have, though, is as I've been looking through these materials over the last few weeks, I did pull out the work that was done a couple of years ago on the Main Care Redesign Task Force that the Commissioner spearheaded, and I know there was a representative from Maxby on that commission. And there were some suggestions in the report itself about better ways to serve the population of people with disabilities. Then there was also like an addendum at the end of the report that I'm not sure who wrote it,
I think it's pretty good.
but I have a sense that it might have Maxby's fingerprints on it. And there were some really good suggestions there also about potentially better ways, and frankly maybe some more cost-efficient ways to provide better services. So I would love it if for the work session you would pull that out, dust it off, give us your updated thoughts on those.
Certainly, and parts of that are alluded to in this as well.
Fantastic.
We've tried to have at least one vehicle this session to address each of several things, which is unnecessary administrative burden, adaptive technology, remote support to minimize, the need for a person, etc.
And in spite of the Commissioner's diligent efforts and best efforts, I'm still a little bit confused about the interplay between implementation of ASSIST, the rate study, the current need under the current rates, and how they all interplay into the development of this budget. And maybe you can help me understand that a little bit.
I can try. I don't pretend that I understand it fully either. But
Okay, we'll figure that out during the work session.
Yeah.
Thank you.
Thank you.
Thank you. Oh, you did. Okay.
Thank you, I just wanted to make sure nobody else had any questions before I asked the second one. So, of this list of 1,060 people, 586 are already getting some form of services,
Correct.
but some of those would like to be upgraded, as it were, to another level of service. Do you think that the folks who serve this population have the capacity, given how intensive the services are for each individual, how long do you think it will take to ramp up the services or the capacity of your organizations to, say, not only eliminate that wait list, but continue to serve the estimate that you think will continue to be added to that list of needs?
It really does depend on a couple of things. One is, adequate housing is a challenge, without question. When you add to that challenge individuals who may have physical disabilities so that adaptive housing is necessary. If construction is a requirement, then clearly that's a longer term ramp up, if you will. But there are a lot of options under the waiver, including, for example, someone remaining at home with their family, but home support, staff coming in to assist or to support that person. Shared living, which is more of a foster home kind of model. That's what people are most familiar with, I think. But where an individual or family invite someone to come to their home. And that can happen quite quickly. And then everything in between. Vacancies, when someone currently receiving services passes away. That's another option. So it really, even an average time, I don't think would be awfully helpful.
Thank you. Representative Bernstein.
Thank you, Senator. Hi, good morning. Could you just talk a little bit about the transition between children's services going into adults and how, if that's working, not working, how that's affecting a lot of people?
It's very challenging. We're delighted that for the first time in a very long time, the department really has over the last year recognized that coordination between leaving children's service and moving into adult needs more attention. In my summary, I mentioned the group, the task force that was convened, stakeholders group, to look at services. This was a few years ago. Cullen Ryan, who happens to be here by coincidence, Cullen is the chair of a family coalition, the Coalition on Housing and Quality Services, that has just finished developing a white paper trying to show what appropriate transition activities planning should be that the department had asked them to work on, so that hopefully that can become. And Representative McClellan's bill, he is sponsoring a bill that will basically require that transition plan be put into action. That really it?
I think so.
Thank you.
Alan?
Thank you. Senator Hamper, Representative Rotundo, members of the Joint Senate Committee on Appropriations and Financial Affairs, and distinguished members of the Joint Senate Committee on HHS. My name is Alan Cooper Lewis. I live in Orono. I'm the parent of 2 children. One of them has a disability and who is very likely to qualify for services under Section 21 when he reaches adulthood. And I just want to give some perspective from the family. I'm testifying for the initiative on page 8 through 31 of the budget to eliminate the wait list for community-based services provided under Section 21. Based on the support we've shown in previous legislatures and based on the support the executive's shown, I think you all know that the Section 21 wait list is an abomination. I want to thank every member who participated in last year's initiative at the budget close to dramatically reduce the priority 1 portion of the wait list. As I see, there are now 13 people still on priority 1 wait list for Section 29. There used to be triple-digit wait list just in priority 1. These are people who were in adult protective status, yet still weren't receiving Section 21 service that they needed. And I want to thank the administration for including an initiative in the biennial budget to finally eliminate the Section 21 wait list.